Welcome to our second town hall of the year, our seventh town hall, our second on drug strategy. Tonight, it's called Searching for a Drug Strategy. Without further ado, I want to turn this first over to Dr. Tara Gomes and her PhD student, Shaleesa Ledlie. And just quickly, I'll just say that Dr. Gomes is the Scientific Director of Urban and Community Health at Unity Health Toronto and holds a Canada Research Chair in Drug Policy and Substance Use. And Ms. Ledlie is a PhD candidate in Pharmaceutical Sciences at the University of Toronto, Leslie Dan Faculty of Pharmacy. And Dr. Gomes is her, what do you call it, your PhD mentor? Anyway, okay, over to you guys.
Thanks for the introduction, Rob. My PhD defense rides on this. So, as Rob said, I'm Shaleesa, and today me and Tara Gomes are going to be going over some data related to the opioid toxicity crisis in Ontario. So, as many of us are likely aware, rates of opioid-related deaths have now been widely reported on for decades. And this goes back as far as 2010, when some of these initial conversations began, given that this increasing trend was observed. So in 2010, there was approximately 550 opioid-related deaths observed. And if we fast forward to today, we see that the situation has substantially worsened, with over 2,800 opioid-related deaths reported in 2021 alone. We also know that the COVID-19 pandemic escalated this further due to an increasingly unpredictable drug supply related to factors such as border closures, lockdowns reducing access to community-based programs, and overall increased feelings of anxiety and loneliness. So if we look at the first year of the pandemic, we saw that there was about a 79% increase in the monthly rates of opioid-related deaths. And we know that this rate has not returned to pre-pandemic levels. Often when we talk about rising rates of opioid-related deaths, we know that this is very directly tied to changes in the unregulated drug supply, which has increasingly changed to being almost entirely composed of fentanyl and potent fentanyl analogs. So if we look at this trend over time, we see that around 2015, the involvement of fentanyl in opioid-related deaths really began to rise, and this has skyrocketed since then. So in 2021, about 1 in every 27 deaths among people under 85 years old were opioid-related in Ontario. And if we look among younger adults in their 20s and 30s, we see that this is as high as 1 in every 3 deaths, really highlighting that people are often young when they die of opioid-related toxicities. So if we look at the current situation in Ontario today, we see that about 86% of all deaths involved fentanyl in early 2023. And this has risen from around 70% in 2017 and 2018. And I think it's really important to note here that only 1 of every 10 deaths actually involve only prescription opioids. We also see that around 65% of deaths involve stimulants and had benzodiazepines detected, which really reflects an increasing prevalence of polysubstance use and also the more frequent addition of benzodiazepines to the unregulated supply. And we know that the combination of fentanyl and sedatives can be really dangerous and also further complicates responses in the event of an overdose. When we look at mode of substance use, we saw that over half of deaths occurred when substances were inhaled. And this is pretty in line with changing substance use preferences among people who use drugs, where there's an increasing trend in the inhalation or smoking of drugs as compared to injection drug use. We also know that about 3 of 4 deaths occurred when there was no one present to intervene by either administering naloxone or attempting resuscitation. And finally, we see that in the first year of the pandemic, about 170 deaths occurred among people under 25 years old, highlighting this increasing burden of death among younger adults. So all of this together really helps to highlight why it's important that we have a multi-pronged response to the drug toxicity crisis that really recognizes that there's varied needs among people with different preferences of substance use, among different demographic groups, and among people who reside in different geographic regions of Ontario. And with that, I will pass it over to Tara to dig into this a bit further.
Thanks so much, Shaleesa. So what I wanted to do, if you just go to the next slide, thanks, Shaleesa, is talk about that first piece, which is around the varied populations, because I think when we discuss this issue a lot and hear about the potential responses, there's often a lot of focus on treatment and the fact that, if we could just focus on treatment as a response, this would really get us to where we need to be. And I think there are a couple of things that I want to just discuss and disentangle there. The first is that what that doesn't recognize is when we look at people who lose their lives to opioid toxicities, about a third of people in Ontario who are experiencing these fatal overdoses don't have a diagnosis of an opioid use disorder, or what you might more commonly refer to as an opioid addiction. They're not actually eligible for treatment. These are typically people who are, recreationally or occasionally using drugs and are experiencing that harm from this very unpredictable and potent supply that Shaleesa just described. So treatment will not actually be an option to people who don't have one of these diagnoses. And so that's one of the first reasons why I think it's so important for us to expand our view beyond just focusing on treatment as a response. The second element of this that I think is really important is that we know that in Ontario, there are about 70,000 people who started treatment in the last year. So there are thousands of people accessing treatment. These are medications like methadone and Suboxone that you might hear talked about. But we also know that about a quarter to a third of people who start treatment stop within the first month. And this is for a variety of reasons that we can get into, but we know that treatment does not always work for people for a variety of reasons. I know many people who've tried treatment sometimes dozens of times, and it's just not the right fit for them. And so when we bring this all together and realize that there's a large portion of people who use drugs who don't have a diagnosis of opioid use disorder, aren't eligible for treatment, and even among those who do have one of these diagnoses, there are many who have tried and tried again and again to access traditional modes of treatment, and it is not working for them. It really, I think, helps us understand why we need such a wide variety of options around treatment, around low barrier treatment, and around harm reduction responses to help keep people safe. Shaleesa also mentioned the various populations and that we really need to kind of adapt and think about how to adapt responses to their needs. I'm just going to touch on a few very quickly here. One of them is our population of people experiencing homelessness. We do know that a large number of deaths occur among this population. And in some work we did early in the pandemic, we saw that 1 out of every 6 opioid toxicity deaths that occurred in those first years of the pandemic were among people experiencing homelessness. And a lot of time, these deaths occur within shelters, within supportive housing, within the hotels that were set up to provide this temporary shelter in the pandemic. And so it speaks to the need for us to think about our various responses to supporting people who are vulnerably housed or experiencing homelessness. If we focus just on the housing and the shelters and don't think about integrating programs and services related to substance use, we're putting people in a situation where they may not have the supports that they need. They may not have safe spaces to use drugs or people present to intervene, and they're losing their lives in these settings that are set up to help them with their housing. And so when thinking about this population, I think it's really important for us to think about how we bring together the kinds of programs and services that we need to support people in their housing and with substance use at the same time. Another population that we talk about a fair amount is First Nations people, Indigenous people more broadly, but particularly First Nations people, where we have really strong knowledge of the fact that there is a high concentration of opioid-related deaths in this population. There's also high prevalence of substance use disorders, which can be tied back to our history of colonization and the harmful effects of our residential school system. And what's really important is when we see these high rates, we also see that they have been accelerating more quickly. And they are occurring not just among First Nations people living within communities in more rural settings, but we see a very large number occurring among First Nations people also living within large urban centers. And, we work very closely with the Chiefs of Ontario and with community partners in all of this work. And what we hear time and again is that we really need to make sure that our responses are also set up to be accessible and to be culturally appropriate to First Nations people, both those who are living within First Nations community and those who are living in larger urban centers who still need access to culturally relevant and safe spaces for them to access this kind of healthcare and these kinds of services. And then finally, Shaleesa touched on this in terms of youth and adolescents and young adults. We have seen this rapidly climbing trend in opioid-related harms in these younger populations against a background of actually reduced access to treatment. And so this is a newer population that we're really starting to talk about more and more in terms of what are the kinds of services that we can create that are going to meet the needs and be accessible and desirable to our younger populations to try and stem this harm that we're starting to see really grow over the last few years in our younger populations, because they really have different needs and different comfort levels with accessing programs and services. And we need to make sure that the way we think about this is also framed around the needs of our younger demographics. And then finally, I know that, we're talking here at a Waterloo town hall, and I've been talking a lot about Ontario-specific data. I think part of this was to set the stage, and we're going to have a lot more conversations around more local elements. But one thing I want to touch on as well, this affects all of Ontario. We do see variability across the province, and I've highlighted Waterloo here. This is all the death rates from opioids across Ontario, and you can see there's a wide variety in rates of opioid-related deaths, but it's happening everywhere. We also know that the modes of substance use, inhalation versus injection, varies across the province. Accessibility and use of cocaine and methamphetamines varies across the province. So while we need these responses in all parts of the province, we also need to make sure that we're tailoring those responses to the individual and unique needs of each community. That's why I'm really glad that Jeff is going to speak next, where he can really speak more to the specific context of Waterloo itself. And I will just end on this slide, which is to say that, what we've really tried to do to set up this town hall and the conversations is to lay the groundwork for what we do know, because we know a lot. We know how things are changing. We know that this is largely a crisis of the unregulated or illicit drug supply that is very potent and unpredictable, that ways people are using drugs and the combinations they're using are changing, and that so many of these deaths happen when people are alone. And all of this helps inform these responses in terms of making sure we have safe spaces for people to use drugs, that we have safer alternatives to this unpredictable drug supply, that we do have low barrier accessible treatment for people, and that we're also thinking about the impacts of the criminalization of drug use on individuals and how decriminalization could play a role in helping support people who use drugs as well. And across all of these, making sure that we think about how to tailor all of this to the unique needs of different populations and geographies. So I'm going to stop there. I probably went a bit over time. I'm sorry, Rob, but
no problem. No problem, Tara. I just wanted to ask you, two things stuck out with me early, and I see they're in your 5 here. Was the inhalation issue, and you had noted 3 or 4 deaths, no one around. And I'm guessing inhalation is growing as a cause of death in communities, but what can we do about those situations? Is there a policy or any suggestion for communities to deal with that issue?
Yeah, it's a great question. I know, Jeff, you wanted to speak about this as well, so I can also see if you want to chime in, but I would say that there are different harm reduction supplies that can be distributed around injection and inhalation. So thinking about things like straight stems and other supplies that can be provided to recognize the shifting way people are using drugs. But I think the other piece is if we think about the types of services we provide. So if we think about supervised consumption sites, for example, they're primarily set up to support people who are injecting drugs, not smoking and inhaling drugs. And it's incredibly difficult for people to try and build in that infrastructure because of just the cost and infrastructure and approvals that are needed to allow for inhalation within those spaces. So I think that there's a real need for us to really think about how we can adapt the services that we have so that we can provide safe spaces for people to use drugs, regardless of the way in which they're using drugs, and not focusing just on injection drug use as the primary mode of substance use.
Just one last question, the way we did, like, as I chat with the others here who are from other provinces, and we see the province takes more of a hands-on role in terms of drug strategy or policy within the province. And in Ontario, it's fractured amongst the different municipalities. Does that hinder us in our ability to accomplish advances in this area?
Fragmentation across all levels of government hinders us, I think, because, federally, provincially, and locally, there are different leaders and different priorities and different strategies. And so I do think one key thing we need to do is find ways for people to see past political lines and work together and work with research and evidence. And I say this as a researcher, so I'm sure I come at this from a biased view, but I think we know a lot. And there are a lot of researchers who are working hard across the country to understand what's needed and also how those needs differ between BC, Alberta, Ontario. And so we actually just need people to come together and be willing to listen to that and put their kind of political ideologies to the side and try and work together to figure out the best way forward.
Okay, well, Tara, Shaleesa, thank you very much for your presentation.